Good evening. My name is Kevin Bergerson, and I am the Patient Education Program Senior Coordinator for the Colon Cancer Alliance. And on behalf of the Certified Patient Navigators and the entire patient support team from the Colon Cancer Alliance, I would like to welcome you to tonight's webinar, It Runs in the Family, Colon Cancer and Genetics. This evening, you should be very excited about this topic, particularly if you're here tonight to learn more about how to better understand your family's health history. About 1 in 4 patients have a family history of colon cancer that could suggest a genetic and/or hereditary factor. This evening, we will learn more about how your family history can make a big difference in preventing and treating colon cancer. We will learn what percentage of colon cancers are caused by genetic mutations, as well as what an inherited genetic mutation diagnosis means for those with a colon cancer family history. The webinar will provide attendees with the red flags that are used to identify individuals and families who are appropriate for genetic testings. We'll talk about what you can do to reduce your risk of cancer after being diagnosed, and after being diagnosed with hereditary cancer syndrome. And we will discuss the newest technologies in the world of cancer genetic counseling. We will learn the cancer risks associated with different syndromes and how genetic testing can help identify family members at risk for cancer. Finally, the webinar will discuss how hereditary cancer panel tests can identify more people who are at risk and relieve the burden of picking the right test. Before we get much further into the webinar, I want to let all of you know about this time tomorrow. All of you in attendance will receive a follow-up email with a link to the feedback survey about this webinar. The Colon Cancer Alliance values your opinion and would be greatly appreciative to hear your honest feedback on how we can make delivery of our webinars better and for any ideas for future topics. Please look for that email, and I would very appreciative if you would take the time to take that online survey. Help us to help you. Before I introduce our speaker this evening, a quick note here about questions. We've always envisioned our webinar to be interactive, where attendees can pose written questions via the GoToWebinar server for our presenter to cover. After our speaker has finished presenting, we may be able to address a few of the questions presented by attendees during the webinar. Please note that we are only accepting questions posed online using the webinar control panel. To submit a question for consideration, click on the small plus sign located next to the word questions on your webinar control panel located on the right side of your screens. Then type in your question and hit enter. As a reminder, our webinar presenters are willing to answer your questions to the best of their ability, but please remember our presenters are here to inform you only, and any specific questions regarding your individualized treatment should be discussed with your personal clinician and healthcare teams. To get the most out of this webinar, we strongly encourage you to ask questions. All questions not already addressed during the speaker's presentation will be posed to our presenter on a time-available basis after their PowerPoint. If we run out of time, please note that any questions that we're unable to get to will be collected and followed up on later. So please accept my apologies in advance if your particular question does not get asked. But we will follow up with that. And with that, we will introduce our speaker. Our presenter this evening is Jamie Wilmot. Jamie earned her undergraduate degree in biology at Harvard University and then worked for 3 years at the Dana-Farber Cancer Institute as a clinical research coordinator in the GI oncology department before getting her master's in genetic counseling at Brandeis University. She is currently working as a genetics counselor at Myriad Genetics in Salt Lake City, Utah, where her special focus is on Lynch syndrome and variant classifications. She enjoys playing the saxophone and is the proud owner and handler of a certified therapy dog who cheers up the kiddos at the local children's hospital. And with that, I would like to turn control of the webinar over to Jamie this evening. Jamie, welcome.
Thank you. Thank you so much, Kevin, and the whole Colon Cancer Alliance for having me tonight. I'm really excited to share this information with you guys. And are we live?
You're good to go.
Everyone see my screen? Okay, great. All right, so let's get started. Some of the goals of today's discussion, some of our learning objectives is, as Kevin mentioned before, I'm hoping that after this webinar you'll understand a little bit more about hereditary cancer and some of the underlying causes, some of the family history features that we look for in hereditary cancer, also the traditional single syndrome risk assessment and the genetic testing strategy, and the recent shift that we've had in the paradigm toward hereditary cancer panel approaches. So to start off, is all cancer hereditary? No, it's not, and actually most of it is not. There is, if you look at this pie, there's about a little 5%, 5 to 10% sliver that is hereditary, and what that means is that people who have a specific gene mutation are more likely to develop cancer because of this mutation. And of all the cancers that we see, only about 5 to 10% of those are hereditary. Another 20 to 30% of those are what we call familial, which means that maybe we see this in a family more than we expect. We see certain cancers in a family more than we would expect in just the general population, but we don't have an exact gene that we can pinpoint for it. And maybe in the future, you will find more genes and that pie might shift a little bit. But right now where we're at, we can find hereditary causes for about 5 to 10% of cancers that we find. And then the rest are what we call sporadic cancers, which means that essentially they just happen. It can be facilitated by environmental exposures. It can just be bad luck. There are lots of things that can cause cancer. Just aging, can cause mutations in genes that can lead to cancer, and I'll talk about that in just a minute. So how does cancer, and specifically hereditary cancer, develop? The typical process is that for every gene in your body, you have 2 copies, and most of the time they're normal copies without mutations. And as we age, as we're exposed to UV light or to any kind of environmental exposures, we can develop what we call somatic mutations. It means they're not mutations that you're born with, but they're mutations that sort of happen, sort of a proofreading error as your DNA is replicating, because your cells are constantly reproducing themselves and replicating, and sometimes they make errors. So if you look at the top line, we start out with 2 normal genes, and then somewhere along the line, one of these genes becomes damaged. That's still enough function for your body to protect itself from developing a tumor, because it has that one gene that's working properly. But occasionally, and this is what we call the 2-hit hypothesis, there will be a second hit on the other gene. So there's constantly errors happening. As long as they don't both happen on the same gene, you should be protected from developing a tumor. But in this case, we happen to have a hit on the same gene on both copies of the gene. And that's when things start to go a little haywire, and it can develop into a tumor and cancer as we know it. Now, people who have hereditary cancer syndromes, like I'm going to talk about tonight, are at a bit of a disadvantage because they inherit a copy of a damaged gene. So they don't start out with 2 normal copies of genes in every cell in their body. They start out with an inherited damaged copy and an inherited normal copy. So they only really need 1 hit to happen in order to develop a tumor. So that's why their risks are so much more increased. You can see how you can develop cancer, how it can happen in someone who has 2 normal genes, but you can also see how it's much easier to happen in someone who already has 1 copy of a gene that's not working properly. So what are some things that we want to think about when we're looking at family histories and evaluating whether they might be a family that has a hereditary cancer syndrome? Well, we want to think about multiple young, and rare. So multiple cancers are, a combination of cancers on the same side of the family. We think about the same types of cancer or cancers that are in the same group. So maybe we see 2 or more people who have colon cancer, and there's someone else who has uterine cancer. That's all part of that can be part of a particular syndrome, and that can catch our eye to make us think, maybe this is something else. Maybe this is something more going on here than just chance, than just sporadic cancers. Some of the other combinations we think about are breast and ovarian cancer, or melanoma and pancreatic cancer. Another thing is young cancers. As I said, aging is one of the biggest things that delivers damage to your DNA. So as we get older, it's inevitable that the risks for cancer go up. But if we see people developing cancer in our families, usually before the age of 50, 50 is not a magical number, but it's just sort of where experts have kind of drawn a cutoff to have something somewhere. When we see people developing cancer before the age of 50, particularly breast cancer, colon cancer, uterine cancer, that's when we start to get suspicious. That's kind of a red flag that makes us think something might be going on in this family. And another one that we think about is rare cancers. So these are cancers that don't happen often, and a lot of the times when they do happen, they're part of a syndrome. So ovarian cancer is pretty rare in the general population. Male breast cancer and triple-negative breast cancer are also pretty rare in the general population, but they're more common in the population that has these hereditary cancer syndromes. When we think about colon cancer, we think about colon cancers that have abnormal pathology features. So when you get when there's a colon tumor, they take it out and they look at it a bunch of different ways. They test to see the stability of it. They test to see what proteins it's expressing. And sometimes when it comes back with some abnormal patterns, that might clue us in to think, this is something we want to look at a little more carefully. This looks like something that might be caused by hereditary cancer syndrome. Uterine cancer is another one where we want to look at the pathology and see, is this expressing different patterns that we would expect in a sporadic cancer. And another one is to see, are there multiple colon polyps? And I'll talk a little bit about how colon polyps can turn into colon cancer. When someone undergoes genetic testing, there are basically 3 possible results that you can get. You can get a positive result, which says you have an increased cancer risk, and there's usually some medical management that's associated with people who carry a mutation and have this increased cancer risk. You can also have a negative result, and the negative result you can see branches out because it means 2 different things depending on what we already know about your family. If we already know that someone in your family has a mutation that causes a hereditary cancer syndrome, this is the best kind of result that we can get, the most informative kind of result we can get. It's called a true negative. And what it means is there is a hereditary cancer syndrome that's causing cancer in your family. It's linked to one specific gene, and we've tested you for it and you don't have it, which means that your risk for cancer goes back to the general population. So for someone who has, say, a mother who had colon cancer at age 40, and say your mother gets tested and is found to have a mutation that explains why she developed colon cancer, we can test you then for that mutation. And if you don't have it, you are back to the normal population risk, which is great news for people who are informative negatives. For people where we don't know, we haven't already explained what's causing the cancer in the family, this is still a good result. We know, we've ruled out that you have a mutation in any of the genes that we test for, but it still doesn't exactly explain what is going on in your family. So it could be that there are other people in your family that have a gene that's causing a hereditary cancer syndrome and you don't have it. Or it could mean that your family falls into one of those buckets of familial where maybe it's a gene we haven't identified, or maybe it's just something that seems to be clustering in your family for reasons that we don't understand. And those people should still undergo, should be somewhat should definitely be reassured by the fact that they don't have a hereditary cancer syndrome, but should still follow, have some kind of heightened awareness based on what we do know about their family. So if there's a lot of colon cancer in their family and you test negative, that's great news. We know that there's not a particular mutation that's causing cancer that we need to worry about in you, but we still haven't fully explained what's going on in the family. So you should still be cognizant of your family history and managed based on that. And then sometimes we'll get something called an uncertain variant. And these are the types of results that we like least, but unfortunately in genetics we don't know everything, and these results can sometimes happen. And what that means is that we might find a change in the gene, but we don't know whether it's harmful or not. So if you think about the word color, and the way that we spell it in the US is C-O-L-O-R. When you go to England or Europe, they spell it C-O-L-O-U-R. That extra U doesn't change the way you pronounce it, doesn't change the meaning of it. It's just a difference. And most of the things that we find, most of the changes that we find in our DNA are exactly that. They don't make a difference. They don't increase your cancer risk. But we just don't know. So we continue to look at those uncertain variants and hopefully at some point be able to categorize them as either completely benign and non-harmful or something that is harmful and causes an increased risk for cancer. If you are found to have a gene mutation, all of your first-degree relatives, so your siblings, your parents, your children, have a 50% chance of having the same mutation. And it's just a flip of a coin. It's not something you can predict, and there's no way that you can know it. There's no way that a family member can know it without getting testing. Testing, like I said, is the only way to identify the gene mutations. If you do have a gene mutation, sometimes you might want to know whether it came from your mother or your father. Not to blame them, because there's absolutely nothing they could do about it. It's all chance. But to alert other family members. In this case, you can see that we have on the mother side of the family, we have an uncle who has 2 children that are cousins. If you have a mutation and we test both your mother and your father to see where it's coming from, if it's coming from your mother's side, then it's important for the uncle and the cousins and any other family members on your mother's side to know about this so that they can get tested. And regardless of the hereditary cancer syndrome, you can get this from either your mother or your father. Some people will think with something like breast cancer, you can only get a gene that causes breast cancer from your mother, but that's actually not true. You can get genes that cause any kind of cancer from both your mother or your father. So it's important to remember that. So now I want to talk about some of the specific syndromes that we see in hereditary colon cancer. The most common, when we think about that pie that I showed at the beginning, we have that small slice that is hereditary colon cancer. And of that small slice, we have a few different syndromes that we think about. The most common syndrome, which accounts for 4% of hereditary, or 4% of colon cancers, is Lynch syndrome. The other 2 syndromes that are less common, but still something to think about, are familial adenomatous polyposis, which is caused by the APC gene, and MYH-associated polyposis, which is caused by the MYH gene. And these can sometimes have overlapping features, and occasionally there are people who might have more than one syndrome. It's rare, but it does happen. So the first syndrome, and the most common that I want to talk about, is Lynch syndrome. It's also been called in the past hereditary non-polyposis colorectal cancer, so you may have heard it referred to as such. The population, we see this, the estimation is about every 1 in 300 to 1 in 500 people. It's associated with a significantly increased risk for colon cancer and also endometrial cancers, and a few more cancers that I'll touch on. It's caused by mutations in 5 different genes, which you can read there, and it shows autosomal dominant inheritance, which means, as I was showing you before, if you have a gene mutation, there's a 50-50 chance that you will pass that on to your children. There's a 50-50 chance that your siblings will have it, because you only need one copy of the gene to have a defect in order to have this syndrome. And I showed you a little earlier why that is. So what kind of risks are we talking about? It's pretty significant when you compare it to the general population. When we look at the risk for colon cancer by age 50, in the general population it's extremely rare, much less than 1%. But in patients who have Lynch syndrome, it can be up to 25%, just the chance of developing colon cancer by age 50. And when we look at those risks up to age 70, in the general population it's about 2%, but in patients who have Lynch syndrome, it's up to 82%. So you can see it confers quite an increased risk of cancer. And why do we see this increased risk of cancer? First of all, it's because of what I showed you before with the two-hit hypothesis, because every cell in your body already has one hit against it on this gene. But what we see in clinical practice is in general population, we'll see someone have maybe an adenoma, which is a polyp. And that polyp will usually develop, if you leave it, it'll usually develop into cancer in about 5 to 10 years. And that's why in the general population they recommend colonoscopies about every 5 to 10 years, because it's a slow progression, a relatively slow progression from this polyp to turn into a full-blown cancer. But in Lynch syndrome, we actually see these polyps developing much more quickly. So the typical progression from a polyp to a full-blown cancer is 1 to 3 years, which is why we recommend more frequent colonoscopies for patients who have Lynch syndrome. So what do we do for patients who have Lynch syndrome in terms of their colon cancer risks? We start colonoscopies a lot earlier than we do in the general population. In the general population, we start colonoscopies about age 50. In patients who have Lynch syndrome, we tend to start at about 20 to 25, or 2 to 5 years prior than the earliest colorectal cancer in the family. So if you have, someone in the family who had colon cancer at age 20, they might recommend starting you in your late teens, which is early, but we want to make sure that, we're catching everything. And those people who have Lynch syndrome generally have colonoscopies every 1 to 2 years. And I explained, because of the accelerated progression, why that's necessary. Cancers and polyps in patients with Lynch syndrome are often found on the right side of the colon, which is a little farther back and a little harder to get to. So it's very important that we do full colonoscopies and not just sigmoidoscopies, and we get, to the very end of the colon, to the right end of the colon. The good news is that studies have shown that this reduces your colon cancer risk. So you saw that huge number, that really high risk, which can be very scary. But you can reduce your risk by following these guidelines by over 50%. And you can reduce overall mortality by 65%. And some of the reason for this is that we find these cancers at an earlier stage. We find them either while they're still polyps, or maybe when they're very early stage 1, stage 2 cancers that are more amenable to treatments. Another thing about Lynch syndrome, I know we're talking about colon cancer, but I also want to mention that Lynch syndrome does increase the risk for gynecologic cancers. Specifically endometrial cancer, you can see that one's the biggest risk. By age 70, the risk can be up to 71%. It also causes an increased risk for ovarian cancer. It's not quite as high, but it's up to about 12%. And I do want to point out that I told you that there are 5 different genes that can cause Lynch syndrome. Some of these have slightly different risk figures. So one gene might be a little more, one gene might be a little less, but for the purposes of this presentation, I'm sort of showing you a general overview. So for gynecologic cancers, there are also some management guidelines that we can consider. There are some surveillance options. They're not great. They include some ultrasounds, some biopsies, some random biopsies, testing for tumor markers. And we might begin those at age 30 to 35, although there's not been great evidence that these actually reduce the reduce the cancer risks. So generally what we recommend for these patients is a surgical management, which is having a hysterectomy and also having your ovaries removed. And usually people will want to wait until after childbearing so that they can go through childbearing and have their children and complete their families, and then maybe think about removing those organs to prevent some of those very high risks for cancer. Lynch syndrome also increases the risk for a second cancer. So just because you've gotten one cancer doesn't necessarily mean, okay, I've gotten my Lynch syndrome cancer, it's out of the way. Unfortunately, it doesn't quite work like that. So when you're diagnosed with a Lynch syndrome cancer, within 10 years, there's up to a 30% chance that you could develop another Lynch syndrome cancer. So say you're diagnosed with colon cancer. If you're a woman, you might be diagnosed with another colon cancer or an endometrial cancer within the next 10 years. And within 15 years, that goes up to about 50%. And you can compare that again to the general population where, of course, there's always a risk of getting another cancer, but it's much lower in the general population than it is in patients with Lynch syndrome. There are some other guidelines for patients with colon cancer. Once you've been diagnosed with a colon cancer, some surgeons may choose to do a more complete surgery or remove more of your colon than they would if you were someone who didn't have Lynch syndrome. And the goal of that is just to reduce the amount of colon tissue and reduce the chances of, polyps and cancers developing. Or, if you're only removing part of the colon, we want to make sure that we're still doing annual colonoscopies to look at what's left of the colon to make sure that there are no polyps developing, no early cancers developing. There are some other cancers that we see in Lynch syndrome. They're not nearly as common as some of the other ones that we just talked about, but we do also see increased risks for gastric cancer, which is stomach cancer, hepatobiliary tract, which is kind of the bile ducts, ureteral and renal pelvis cancer, small bowel cancer, brain and nervous system cancers, usually glioblastomas, pancreatic cancers, and sebaceous adenomas, which are a certain type of skin tumor. And there's also management that we can do for some of these, including an upper GI scope, a capsule endoscopy where you swallow a pill with a camera in it that goes through your whole digestive system. For the cancers of the urinary tract, there's some urinalysis that can be done annually that can kind of catch maybe some blood in the urine or some tumor cells in the urine or something abnormal in the urine. For the central nervous system cancers, some people will do sort of a physical examination every year to make sure that there's not any neurological deficits that they're seeing. Kind of when your doctor makes you stick out your tongue or, touch your nose and touch his finger. Those kinds of things can be helpful in maybe identifying brain tumors. For pancreatic cancer, there's not a lot of recommendations. There's not a lot of great screening for it. There are a lot of really good clinical trials that are going on right now. So that's something that I think providers usually talk to their patients about who have either Lynch syndrome or any of these other hereditary cancer syndromes which include pancreatic cancer in the spectrum. So thinking about Lynch syndrome, what are the red flags? I know I talked kind of generally at the beginning about that multiple, young, and rare, but more specifically, what do we think about? When you're a patient who doesn't have cancer and you're looking at your family history, these are the kinds of things that maybe might prompt you to talk to someone about, getting some genetic testing to evaluate your risk. If you have 2 or more relatives who have a Lynch syndrome cancer, and we talked about kind of that list of them, specifically if there's one before the age of 50. That's that young and that multiple kind of coming together there. And then if you have 3 or more relatives with a Lynch syndrome cancer at any age, that's definitely, cause for concern and cause for some further discussion at least. And if there is someone in the family who has a known Lynch syndrome mutation and you are in that direct bloodline, it's definitely something that you should think about, wanting to know if you are also someone who carries a Lynch syndrome mutation, or if you're one of those true negatives who goes back to the general population risk. For patients who do have a cancer diagnosis, we again think about colon or endometrial cancer diagnosed before the age of 50, someone who has some of these abnormal pathologies before the age of 60, someone who has an abnormal pathology, going a little bit further, looking at some of these protein patterns and some of these, stability of DNA in your tumor. People who have abnormal results on that are someone that we want to think about for perhaps further testing or at least further discussion. Someone who has 2 or more Lynch syndrome cancers at any age, so say you're diagnosed with a colon cancer when you're 50 and endometrial cancer when you're 60, that's something that we'd want to investigate. Someone who has a Lynch syndrome cancer and has 1 or more relatives who also has a Lynch syndrome cancer, or again, someone who has a previously identified Lynch syndrome mutation in the family. So we've talked about this. There is some overlap between these syndromes, and I want to talk about the other 2 for just a minute. There are what we call the polyposis syndromes. There's familial adenomatous polyposis. There's an attenuated form of the familial adenomatous polyposis, and there's this MYH-associated polyposis. The typical familial adenomatous polyposis that we think of is usually pretty severe and usually something that's caught pretty early on in life. These patients might have hundreds to thousands of colon polyps, and they are at a very high risk for colon cancer, for one of those polyps developing into colon cancer. There is an attenuated form of that, which means it's a little less. We tend to see less than 100. We tend to see less than 100 polyps in individuals. But even that, even someone who has 50 polyps, that's a lot of polyps, and that's a lot of chances for something to develop into a colon cancer. For the MYH-associated polyposis, this one has a very variable presentation. Sometimes we see it in patients who have a single early onset colon cancer and no polyps, and sometimes we'll see patients who have polyps, up to 1,000 polyps. The one difference with this syndrome is that instead of being autosomal dominant, which means that you only need 1 copy of the gene to be not working in order to cause this syndrome, you need 2 copies. So for MYH-associated polyposis, you need to inherit 2 faulty copies of the gene, 1 from your mom and 1 from your dad. And what are the red flags for some of these polyposis syndromes? Anyone who has more than 10 polyps in their lifetime, more than 10 cumulative polyps. Anyone who has a colon cancer and also has multiple polyps. And as always, someone previously in the family who's been found to have a mutation in one of these genes. So in the past, as we found out about these syndromes, we've sort of thought about genetic counselors and doctors sitting down and evaluating the family histories and saying, what does this look like? Does this look like a polyposis syndrome? Does this look like Lynch syndrome? Does this look like a breast cancer syndrome? What does this look like? The problem is that there's a lot of overlap. And so there's sort of this sequential testing process where you test for maybe what you think is the most common. And there's some amount of uncertainty. You don't know just by looking at someone. There are certain cases that are absolutely textbook, but there are some cases that really aren't and don't quite look exactly like we would expect Lynch syndrome or a BRCA1 and 2 mutation to look like. So in order to eliminate that uncertainty, we've moved to sort of a panel approach. And what we see here is that two different ways we can look at it. When you think of breast cancer, for example, there are multiple genes that are associated with breast cancer. Yeah, there's BRCA1 and 2, which are, the most common, but there's also this whole other host of genes that can cause an increased risk for breast cancer. And then there are multiple cancers that can be associated with a single gene. So, for example, the TP53 gene is associated with a variety of different cancers, and so is Lynch syndrome, like we talked about. So it might be harder to just kind of pinpoint exactly what we're looking at. So what's been developed is these panel tests, where instead of testing, I'm going to test you for this gene, and then if that's negative, I'm going to go to this gene, and then if that's negative, I'll go to these genes. There are many labs that have come out with these panel testings, and as we're getting better at doing genetic testing, and the price for testing genes has sort of come down a bit, and the machinery's gotten a little bit better, we're able to test multiple genes at once. And this is an example. At Myriad, there's a test called MyRisk, and this looks at 25 different genes that are associated with a broad number of cancer sites. We tend to focus on the 8 cancers that you see listed: breast, ovarian, gastric, colorectal, pancreatic, melanoma, prostate, and endometrial. But there are some other cancers that we definitely see that are associated with some of these. And Lynch syndrome and the polyposis syndromes are all included on this panel. And once again, to go back to this, we have these possible genetic test results. Either you're positive and there's an increased risk for a cancer, and usually there are some recommendations, like the ones that we talked about for Lynch syndrome, to reduce your risk for cancers. Then you can have a negative result, which, as I said, is split into a true negative, which means that we know that someone else in your family has a mutation and you don't have it, or a negative result where we still haven't necessarily explained the family history, but we know that you don't have a mutation in any of these 25 genes that we've looked at on the panel. And then there's, of course, the uncertain variant, which is, again, not our ideal result, but sometimes it does happen. And at Myriad, we have a lifetime commitment to patients who have these uncertain variants. When we see an uncertain variant, we are every day looking at all of our uncertain variants and looking for new evidence to reclassify them into one of the positive or negative groups. And like I said, there are many ways that we can manage hereditary cancer risk. For some, it's increased surveillance, like colonoscopies. For some, there's chemo prevention. I know there's some exciting new research going on specifically with colon cancer, talking about aspirin that can reduce the risk for colon cancer, and I know there's a lot of studies being done to see if this is true for patients with Lynch syndrome, and if that does, turn out to be something that's helpful, it's something that may be used by doctors more and more and added to some of these guidelines. And then there's always risk-reducing surgery, which, unfortunately is sometimes the best option, and although it does sound drastic, when you're facing, an 80% risk or a 60% risk of cancer with maybe one of these organs where there's not great screening, some people might consider it worth it to remove those organs to get rid of their risk as much as possible. And so I want to circle back to the beginning, and I hope that I've met these goals. I hope that by now you have a better understanding of hereditary colon cancer and some of the causes, some of the family histories that we look for in these hereditary cancer syndromes, some of the traditional single syndrome testing that we think about, and how this multi-gene panels have sort of widened the lens and maybe casting a wider net to hopefully catch more patients who have maybe not some of the most common syndromes that we think about, but some other ones that are also out there and also important to know about. And with that, that's the end of my presentation, and I hope we have some questions that I can get to. We have about, looks like about 20 more minutes, and I'm happy to answer some of your questions.
Thank you, Jamie. Those are some really amazing advances in a very complex world of genetics. I am sure knowing your personal family genetics history is of interest to the patients and survivors in attendance this evening. And that was some great information. At this time, we will be asking our presenter to respond to a few questions as posed by our attendees during the webinar. So if you have any questions and have not submitted it yet, now is the time to do so. Simply click on the small plus sign located next to the word questions on the webinar control panel, located on the right side of your screens. Type your question and hit enter. So with that, our very first question comes to us from Rosa Linda, who asked, what is the risk factor for an unborn child of a patient diagnosed with stage 4 colon cancer?
That's a good question. You know, it depends on whether or not that person has a hereditary cancer syndrome. Now, just because the patient has stage 4 colon cancer doesn't necessarily mean that they have a hereditary cancer syndrome. And without testing that person to see if it is a hereditary cause, we don't know. If someone has stage 4 colon cancer and they get a genetic test and they find out that they have Lynch syndrome, then the chance is for the unborn child to have Lynch syndrome is 1/2, is 50%. If we're not able to find a hereditary cause for this person's cancer, you know, their children would be at, you know, somewhat increased risk because we haven't explained it, but we can't necessarily put a number on it because we don't, unless we have a direct genetic cause for it. So I definitely think that someone with stage 4 cancer, stage 4 colon cancer, who's worried about a risk to their children, might want to consider genetic testing to see if we can find that gene, and then we can go from there to find out, you know, what is the risk that the child will inherit this gene, and if the child does inherit the gene, what would be their risk then to get cancer.
Okay.
So it's not a solid, you know, it's different from person to person, and it's different from situation to situation. And another thing I wanted to bring up that I realized I forgot to say during my presentation is, how do we get tested? How does someone get tested? And the way you can get tested is it's a simple blood test or a saliva test. You can swish some mouthwash and spit it in, or there are some saliva kits where you can spit into a tube that collects your DNA, and then you send that off to a laboratory who does the testing, and we send those results back to your doctor. And it is something that needs to be facilitated by a doctor or a genetic counselor. So if it's something that you're interested in, definitely don't be afraid to bring it up with your doctor, with your genetic counselor. If your doctor isn't comfortable doing genetic testing or doesn't know much about genetic testing, you know, ask them maybe for a referral to someone who does. And if they're not, there's always websites out there. The National Society for Genetic Counselors is a great website, and they have a tool where you can look up to find a genetic counselor in your area. And that is a great way to find someone who will be able to sit down with you and help you figure out your risks and what to do next and what kind of testing might be appropriate and where to go from there.
Okay. And those kinds of tests that you just discovered, I had a question here regarding the use of, for example, the trademarked Cologuard test, which is, you know, that's a screening test. You can't confuse the two.
Right. In terms of screening tests, when we're looking for the presence of cancer, and screening tests are looking for to answer the question, do you have cancer right now? The questions that we're looking at when we do hereditary cancer testing is, do you have a genetic mutation that has either caused the cancer you already have, or can cause a risk for future cancers?
I have another question from two of our attendees that are very closely aligned. What are the timing for offspring to get colonoscopies for someone who was diagnosed in the mid-40s and somebody who had passed in their mid-40s? The individual who passed had also multiple cancers and familial history of cancers.
Mm-hmm. Yeah, so again, a lot depends on whether or not we've identified the exact gene that's causing the cancers. Some of those different syndromes and different genes have different managements associated with them. But in the case where we haven't been able to find a hereditary cause, I think the general recommendation for colon cancer screening is to start screening 5 to 10 years before the youngest or the earliest onset cancer in the family, or at age 50, whichever comes first.
Okay. And there's a little confusion between what can be described as genetic testing for the individual versus genetic testing for the tumor. Can you expand on that ever so briefly?
Absolutely, yeah. So when we look at tumors, so this is the microsatellite instability and the immunohistochemistry I was talking about, those are more screening tests on your tumor. We look at the tumor and we say, are there any features of this tumor? Are there any proteins that aren't being expressed properly? Does it look like there are certain strands that are slipping, causing this instability of the DNA? If we see that, that's not a diagnosis of Lynch syndrome or hereditary cancer syndrome, but it's a clue that we might want to consider that, because we see those kinds of cancers more often in patients who have Lynch syndrome. So it's not a perfect test. It's not a one-to-one test. You can have these unstable cancers and cancers with different patterns of expression that can be caused by other things, not Lynch syndrome. And you can also have cancers that Lynch syndrome causes that don't have these hallmark features.
Okay, we're doing great. We got about 5 more minutes for questions here. I got a question from Nancy here, whose son has the FAP gene, but her husband and I and her were both tested negative for the gene. What are the chances of her daughter or her children mutating the same gene?
That is a great question. So there are certain syndromes, like Lynch, for example, is one of those syndromes where it's almost always something that's inherited from your parents. But when you are, developing in utero, it is possible for a mutation to happen that develops and is entirely in you. And that is, we call that de novo, or it's a new mutation. So sometimes, and in FAP it's especially common for the APC gene, that has a high sort of mutation rate, a high new mutation rate. And about a third of cases of FAP are actually new mutations, not something inherited from your parents. So there's, a really good likelihood that this was an event that, happened to Nancy's son while he was in utero. It was a mutation that happened and, and was spread, and as the genes replicated, it became part of most of the cells of his body. There are some rare exceptions to that. Never say never in genetics. There are some kind of complicated findings where sometimes a parent can have a mutation that happens in either their sperm or their egg cells, and it's only present in their sperm or their egg cells. So it's not in their colon cells, it's not in other cells of their body, but it happened, during that process that forms sperm and egg. And so thus it was inherited from one of the parents. It could be inherited from one of the parents. Although this, and we call that gonadal mosaicism, it's pretty rare. but it does happen. So for this patient, or for Nancy's son, for her other children, there's a pretty low likelihood that they would also have had this same event. But we can't entirely rule it out that either in the eggs or the sperm cells of the parents that there might be a mutation that happened at that level.
Okay. I have a patient navigator attendee who is asking that they have a patient who is a father, age 46, diagnosed stage 4 colorectal cancer, but tested negative for Lynch. His 32-year-old son just diagnosed with stage 3 colorectal cancer. Should the father be retested at this time for Lynch?
That's another good question. It depends on when the father was tested for Lynch syndrome. As I've said, there's 5 genes that we look at now, and if the father was tested a very long time ago, some of these genes are relatively recent as 2011. So if the father was tested before that, it might be worthwhile to sort of update that testing to see if maybe there's something else. Maybe it's in one of these genes that we've discovered since then. Another thing to think about is that now that we have these panels and that we have all these all these different genes, like maybe APC or some of these other genes that we know to be associated with colon cancer, maybe it may be a good idea for the father to be tested for those genes as well, or the son, either one. A lot of it, depends on kind of the situation. But, it would definitely be worthwhile to update the testing in some fashion. If not an entire panel, then, we can look at what Lynch genes were tested before. But again, one of the benefits of the panel is that it casts this wider net. So all these people before who had Lynch syndrome testing and were negative, it's possible that we missed something that now we know about and now we know how to test for. So it might be important for them to follow up with their providers to talk about, what further testing has been done since, or has been discovered since they were tested, and is that something that would be appropriate for them or their family members?
Okay, I got a question here from Tim. His wife was diagnosed with stage 4 at age 38, and I'm sorry to hear that she passed away, Tim, 4 years later. Tim has 3 young children, but Tim doesn't know her mutation. Should Tim still go through with the lab testing to see if his children have the increased risk, and at what age should children be tested?
That is a really good question. I'm really sorry to hear about your wife, Tim. That is very sad. And, the early onset colon cancer definitely brings up, concerns. That's definitely one of our red flags. In a perfect world, we would always be able to test kind of the index case. But obviously there are a lot of reasons why sometimes that can't happen. I think your children, and if your wife has any siblings, would be appropriate people to get testing to see if maybe we can find a mutation. If someone, if her sister or if one of your children were to test positive for a mutation, that would be a pretty good indication that that's what happened, and that's why your wife developed colon cancer at such an early age. If not, it still doesn't answer that question. It's still one of those uninformative negatives, but it can at least give you some information. Your children can at least know that maybe they don't have that cancer. And in terms of what age to test them, that depends on who you ask. But in the genetic counseling world, we sort of think about one important thing we think about is autonomy. If we're testing children when they're maybe 5 or 6 years old, are they really making an informed decision? Do they really know necessarily what they're getting into? Do they know what's happening? They might not. You might have a very mature teenager who understands the risks and the benefits and wants to go ahead with it. And that's okay. It's kind of on a case-by-case basis. But usually what we say is until children are 18 or at an age where their medical management would change, that's when we should start thinking about this.
Okay.
For, we talked about the medical management for Lynch syndrome, and the change in medical management really starts at about age 20. We talk about colon cancer, colonoscopy starting at age 20 to 25. And so if we were to test a child when they were, say, 10, we would have that information for 10 years without anything to really do about it. Without any recommended interventions. So does it benefit the child to test them so early? The parents may want to know, and that's certainly a consideration. But in terms of that can have an impact on a child, maybe, having genetic testing and maybe being told that they have a mutation or knowing that they have a mutation at a younger age, that has some emotional consequences as well. And so I think the general sort of guideline is to wait until either the child is 18 or until it would change medical management.
All right.
Which in this case turns out to be about the same.
Okay. Well, I'd like to thank everyone for your questions. We did have about 65 attendees out of the 250 some odd folks who registered, and there was a fair number of questions that we're not going to be able to get to because this is a very popular topic. We will be recording those questions, and we'll be reaching out to those individuals who asked those questions, and we'll do our best to answer those in the next week or so. So we will get back to you regarding some of those questions that were posed but we couldn't get to. But we are out of time for this evening. So on behalf of the Colon Cancer Alliance and all of the attendees, I'd very much like to thank Jamie for your time this evening. Thank you. Your expertise and time was greatly appreciated. Do you have any parting comments for us, Jamie?
I'm glad that I got to talk to you guys, and I hope you learned something tonight. And maybe it'll get the juices flowing, get you thinking about your own family histories and how you might be able to talk to family members and get some good information, and talk to a genetic counselor or a doctor about potentially seeing whether genetic testing is appropriate for you. And if this saves one person's life and one person gets a colonoscopy that detects a really early onset cancer or a polyp, then I feel like I've done my job. So again, if you have any questions, please go ahead and submit them, and we'll do our best to answer those offline. Really great to speak to you guys tonight.
Thank you, Jamie. You're amazing. I really appreciate that. Before we go, don't forget to join us next month on September 17th at 7 p.m. Eastern Time for our 11th webinar in the series. Our Conversations webinar series, Never Too Young, Why the Rise? While we know about the rise in this disease in those under 50, recent studies by UC Irvine Health digestive health physicians have put some real and alarming numbers to the hard reality that you're never too young for colon cancer. Join us for this webinar on September 17th as the hematology oncology specialist, Dr. Jason Zell, from UC Irvine presents the facts on this trend, and as well as new research showing what the science is behind the disease and why those numbers are changing, even if the statistics say the risks remain relatively low. Registration for this particular webinar will be opening soon, so please visit our website early next week and register at www.coloncanceralliance.org/webinars. As a reminder, the survey is coming out tomorrow. You'll get an automatic email. Please look for that. We very much like to get your opinion on how we could get more topics for our webinars, as well as what we could do better next time. Thank you all for your attendance this evening. We sincerely hope you enjoyed this webinar. As a reminder, this webinar has been recorded and will be available for viewing next week, and when we rebroadcast the recording at the same website, www.ccalliance.org/webinars. In addition, we'll be posting the five top takeaways and other related information to our blog the week following the webinar. Please check out our blog at ccalliance.org/blog. As always, if you have any questions, you'd like to share some comments regarding the webinar, you can always reach out and comment to me directly at my email address, kbergerson@ccalliance.org. So on behalf of the Colon Cancer Alliance and tonight's presenters, I'd once again like to thank everyone for attending this webinar. I hope you found it informative and value-added. Good evening, and take care, everyone.